Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
I'm good. It's a weekend. We're keeping track of our time for sneak preview for a future episode. But things are good here. How about you?
Yeah, now you tease me. I kind of want to talk about our new endeavor where we're tracking how we spend our time. I'm into day three, and it's super fun. Yeah, it's a total tease for listeners, but we will share how Chris and I spend our lives in a coming
Highly
episode.
scientific study. Only the most rigorous of methods. But there is an app involved, and I think it's going to be super interesting. And I actually was curious if we could get our entire division to do it because I think it would be very, very interesting.
It would be interesting. I have to say, tracking one's time. And so, what we're talking about, we're probably going too far down this road. What we're talking about is just, how much time do I work? How much time do I sleep or spend time with in my family? And when I'm working, what am I doing? It's really tedious to do this.
Yeah, absolutely. And I have to do some retrospective entries. So I put it that way. So yes,
Oh,
highly rigorous.
already.
I was really good until about noon yesterday. So I promise I will get them back in. And I think it's kind of like logging cases when you're a resident or fellow. If like you don't stay on top of it, it's just gonna be this like mountain of work to do down the line.
Right.
Anyhow, that's for a future episode in 2024. So it's our last pod of the year. We get a little bonus Chris or New Year's Eve episode drop.
Yeah, this is a little earlier than we typically release an episode, but we wanted to share one final go. And we have some good stuff to talk about. Just as a quick preview, we have a couple of at least one listener comment and listener question. We have a couple of HBR articles to talk about, and we have a great case. But I want to start by hearing about your journey across the world with your family, about 6 weeks ago now?
Yeah, it was a while ago, but we haven't gotten a chance to talk about it. So, I was invited to speak at the Philippine Orthopedic Association, which, as a Filipino American young man, it was an incredible honor and very meaningful. I mean, I've only been to the Philippines once. I was born in the States.
Wow.
I'd been once when I was in high school. So to get the opportunity to go back was amazing. So thank you to those that invited me, SD Estrella and Nat Zerzillo, a couple of Filipino surgeons that I've met at various points, including, and there are a couple of podcast listeners too. Nats is a big congenital guy, so he's always asking me for more of that, and I have to politely decline.
Nats, we
So,
got you. We'll come back in 2024 with more congenital.
but it was cool. So we decided, you know what, let's go for it. We brought the whole family. So my wife, two kids, an 8-year-old and a 5-year-old, traveling all the way across the globe. And then my father-in-law came and my parents came. They met us there. So it was a big crew, but we had a fun time. Threaded the needle in terms of time off with coupling it with the Thanksgiving week. So and then an extra week before. So it was an amazing trip, incredible honor, great conference, a great opportunity to network and meet surgeons, and yeah, it was fantastic.
Oh, it sounds great. It sounds great. Those it's always daunting to consider and plan those trips and think about time away from work and all that. But I'm sure you will not look back and regret that time. In fact, you'll look back fondly, and your kids hopefully will be even more kind of in touch with family and heritage, etc.
Yeah, I think that was part of it. My kids met cousins that they would have never met before. So that was fun, and they're already trying to plan the next time that we can go back and all that stuff. So, incredible. A couple of odd things that happened. I mean, so we don't have tablets for the kids, but because we have these crazy flights, like the longest one was 14 hours.
Oh
And we're
gosh.
like, if the seat back entertainment goes down, like we're toast. So we went ahead and got a couple iPads for the kids, and kind of got them set up and everything, and it was great. They didn't really use them like that much, and it was like, okay, educational stuff, educational in quotes, like on the iPad, and then like videos and watching was only on like the seat back entertainment thing. But then my son decided he wanted to learn how to text. So of course the iPad has iMessage. And I'm sitting at a conference and I'm actually texting my 8-year-old son, which is super weird, but it's so cute. And it's just like, the intentionality that he has with each word that he's typing and what he wants to say. And it was the best.
Yeah, I continue to evolve with my texting skills. My youngest is 18. She is a bullet texter, so she's the most emotional Goldfarb, and so you can feel and hear with these text after text after text instead of, me, I text with punctuation. They all give me grief. And, old school texting, and there's no punctuation, there's no capitals, and it's text, 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 text. And like my phone's blowing up and I'm like, what the hell is going on? It's so funny.
There's such a thing as an emotional gold farb.
There is.
Is this
There definitely is.
is this the latest product release?
This
I've not
this
seen
is
this version.
the most highly evolved gold farm is the youngest. Yes.
Oh man, better watch out. Future generations of gold farm is going to take over the world more than they already have. My goodness.
Yes, no, she's amazing. And we know exactly what she's thinking all the time.
Ah, yes. Okay, perfect. Generational shifts here. So you've been
Yes.
busy though too. I mean, this has been a busy semester for you. First semester in business school, right?
First semester in B school, check. It was fantastic. It was
First
really
first of
everything I
how
hoped it would
many?
be.
First of
Uh,
how many?
thank you very little for that. I have three more. Three
Okay.
more.
All right.
This is I think, our longest break. So my last classes were beginning of this December of this month, and we had a major marketing presentation. And again, this is Olin Executive MBA program. We had a major marketing presentation and business plan development, and then we had a take-home final in business analytics, which was super interesting, a little daunting. It was advanced statistics utilized for the financial side of the world, whether it be Monte Carlo simulations or regression analyses. Now, clear overlap with what we do in our world, but I would never claim to be an advanced statistician, but I am better today than I was. So this is kind of funny. So we had our take-home final, and these take-home finals are 10 to 15 hours or so. And so we had class Thursday, Friday, Saturday. I worked on it Saturday night for a bunch of hours and Sunday morning for a bunch of hours. I just needed to get it done. It tested the endurance a little bit, but I'm so happy I got it done while it was fresh. And it's just an interesting way to learn. These finals are learning opportunities, which sounds corny, but is really true.
Well, I think the game is different when you're at your stage in terms of your executive MBA program. It's not like you're college student anymore. So you learn differently. You value and relish the opportunities to learn differently because it has much more direct implication on what you do now. So yeah, I think that's great. Your comment about the advanced statistics stuff is interesting because my approach to that is like, yeah, you're not going to be an expert in actually doing it, but you know the language, you know what's possible. You may not have ever heard of some of these things before, and you're going to pull that into your for lack of a better word, daily practice. And it's like when I talk to students about whether to do certain classes as part of a master's program or something. It's like, hey, you're not going to be doing all your own stats, but you'll know how to have a better conversation with your statistician. You know how to read the literature better. I mean, Monte Carlos and advanced regression analysis show up in our medical literature too. So yeah, that's great. That's fantastic. You know what? So that your whole experience with the executive MBA didn't even come up in your recent installation as a Richard H. Gelberman professor. So they're going through all of your amazing accomplishments, and when you had this incredible honor of being installed as an endowed chair, the Gelberman professorship, they didn't even talk about the fact that you're going to business school. That's crazy.
Yeah, well, thank you for the kind words. I'll share one lesson from business school, data wise, and then I'll we don't want to belabor this, but I'd love to acknowledge that the installation. So the point from business school regarding data is, and this was kind of strongly suggested and is so true, is if you have a stream of data, always graph it, always plot it. It's so telling, and that was demonstrated to us over and over in class, and I don't do that enough. I may have some data that I'm thinking about and ask someone to analyze it, but plotting the data makes all the difference in the world. And then, yeah, the installation was something. It was out there for a long time, years. Finally happened. My family came in from Alabama, which was super special. I think they know I'm a hand surgeon. They really have no idea what I do, so now they have a little more of a taste. And really, the other thing that was special was the other people who came in town. Peter Stern, Terry Light, my good friend Kirby Oberg flew in. I didn't know he was coming from California. And then Larry Lanke from Columbia, and Ken Yamaguchi, who's now at Northwestern. A lot of people came in, and this was not just for me. This was a recognition of Richard Government as well. But really amazing turnout. The lesson I take away, aside from the really, it was fantastic, and the dinner afterwards was amazing, and people were, learned a lot. I talked a lot. Fantastic stuff. My take home is, don't miss events. It was so meaningful that Peter Stern came to St. Louis to be there for Richard and I. It just doubles down that principle. Don't miss important events, whether they're important to you or important to someone you care about. Don't miss them.
Yeah, it was honestly, it was an orthopedics Hall of Fame. It's crazy, the people that were there. So, yeah, I mean, I think that, there are things that are meaningful for so many reasons. And, if whatever you can, make it. And I did bend my schedule a bit to make it there for you. So I'm sorry I missed the dinner, but yeah, there was an event for my kid I wanted to be at too. So
Yeah,
sometimes
there's
you can
always
make it work.
Yeah, there's always challenges, no doubt. Anyways, super fun. All right, should we jump in?
Yeah, so I mean, people are like, "Gosh, you guys have been catching up for a long time." So we did want to acknowledge a great review that we have from RJR Cannell via Apple Podcasts from the UK. So thank you for listening. 5 stars. I mean, that's actually you, by the way. Titled "Best Orthopedic Podcast." A beautiful presentation of a variety of topics from clinical, totally approachable and engaging
Hey,
style,
Chris,
unlike.
I'm breaking up. I don't know if it's me or you. Shit. Do you have like good signal?
Yeah, I'm in next to the thing, and I've got all the.
Maybe it's me. Let me see if I move, if I can make it better. We can just pause for a second.
Come on.
Yeah. Wow, that's the same as it was, but okay. Do you want to just start over with the review?
Yeah, whenever you're ready.
Yeah, keep going.
So I love it when we get reviews, and we're fortunate enough to have a great review from RJR Connell via Apple Podcasts from the UK. So thank you for listening over across the pond. Best orthopedic podcast, 5 stars. If you haven't left a review, when you go to leave a review, it's the only way to leave a review is with 5 stars. But entitled Best Orthopedic Podcast. Beautiful presentation of a variety of topics from clinical controversies to technical pearls. We'll get into some of that today, which will be fun. Totally approachable and engaging style, unlike the majority of orthopedic podcasts. Really useful for preparation for ortho exams. So there you go. You get everything. You get prep for your cases, prep for your exams. You get to hear about Chuck and all of his amazing accomplishments. Good stuff. Good stuff. So thank you for leaving that review. Please leave a review on Spotify, iTunes, wherever you get your pods. And then feel free to email us at handpodcast@gmail.com.
Love it. Thank you. Thanks for the review. Thanks for sharing that. And let's, if it's okay, I'll pivot for a listener submitted question from Cal Shaw. Here's Cal's comment and question. I've had a couple of patients with ulnar-sided wrist pain after distal radius fracture that I treated with ORIF and some that were treated non-operatively. I would love to get your thoughts on how you approach ulnar wrist pain and treat it. At what time do you start intervening? After a period of observation, advanced imaging ? Ulnar carpal injection ? Surgery? Perhaps this would be something to consider on the podcast. Indeed, here we are considering on the podcast. So, Chris, I'll paint a scenario. We have a 47-year-old male who falls off his bike, has a distal radius fracture. You did a beautiful open reduction and internal fixation from a volar approach. You tested his DRUJ intraoperatively and found it to be stable. And now he's 4 months out. The radial side of the wrist is doing great, but he's still complaining of ulnar-sided wrist pain. How do you think about it?
Well, I mean, I guess I was prepared for you to give me a case of a 67-year-old woman, because honestly, that is the patient. That demographic tends to be the one that I find having to have this conversation a lot more with. Um, I usually, I guess we could answer your question in a moment of how you handle that patient. I think it is important again to assess stability of the DRUJ. And then I'd love to know your ways on doing that. I do tend to try to ballot the ulnar head and try to manipulate it volar and dorsally in different forearm positions and see if there's any increased laxity compared to the other side. I also I try to manipulate the carpus as well relative to the ulna, so then stabilizing the distal ulna and then essentially rocking the carpus back and forth to see if that generates pain. These are all things that I like to use to look at potential TFCC issues. I'd love to know what.
I'm sorry,
Go ahead.
intraoperatively.
Now, this is stuff I do in the clinic. I do it intraoperatively too, but that's kind of if this conversation is happening after surgery and we're still having ulnar side of wrist pain, which happens to a lot of people. Those are the things that I'm doing briefly in clinic while trying to assess, talk to the patient a bit more. I'd love to know your thoughts on how you assess that, and also what you think the pain generator is on patients who have continued ulnar side of wrist pain after distal radius ORIF.
Yeah. So, first of all, I think one of the points I do make to the fellows is always perform the intraoperative exam after you fix the radius, and do that in supination, neutral, and pronation. And if you have concerns about stability, and hopefully you've tested the other side, so relative stability, then most commonly, if you have concerns, long arm splint in supination. And it does change the patient expectations afterwards, right? Because we all talk about, we'll fix your distal radius and we'll get you in therapy right away, but it's worth it. So that's number one. Number two, I do the same thing post-operatively once not the 2-week visit, but maybe the 6-week visit. And ultimately, most are stable. We don't really know what's going on with the TFCC. And then, of course, if there's an ulnar styloid fracture, patients will focus on that and really be concerned. But the reality is, as we've discussed before, and I think as all of us know, is that ulnar side of wrist pain persists while the distal radius heals, whether it's treated operatively or non-operatively.
Yeah, I think that that's important messaging to. I have that conversation from the beginning when we're talking about surgery, especially if there's an ulnar styloid fracture, because like you said, like the patient sees that they have two fractures. Why are you only treating one? Which is a very reasonable thing to ask. So we talk about that, and I tend to at least when I was in training, there were a number of studies that had been published looking at whether or not to fix the ulnar styloid fracture, and essentially demonstrating that at a year, and then you do have the chance for prominent implants, and that may need to be removed given how there really is no subcutaneous tissue there.
Yeah, it's been an interesting evolution. As you said, when you were in training, we were talking about fixed or not fixed. I think all of us believe don't fix the ulnar styloid unless you really feel like you 100% have to. So it's not even really part of the discussion anymore for me. Whether or not there's a fracture, the pain can persist. Of course, I'm always thinking TFCC and arthroscopy, but don't jump to that too soon. I think my messaging is probably the same as yours, as I tell people preoperatively that ulnar side of wrist pain can persist for a year. It's a good landmark to have for them to consider, and then hopefully it helps manage it better after surgery.
Do you think that the likelihood of having pathology to the TFCC is higher, what that merits actual intervention is higher in that patient that's 47 and likely had a higher energy impact injury than somebody who had a standing level fall?
I 100% do. And of course, fracture pattern can tell you something, whether it's that radial shift of the distal radius fragment or whatever. But the higher energy injury makes me worried more. And certainly a relatively small percentage, honestly, of the wrist arthroscopies I do today are related to a previous fracture, but most are not related to a previous fracture. So as we know, from back in 1995, Bill Geisler's original work.
The late 1900s?
Yeah, the last century. We know that soft tissue injuries happen, but the vast majority just get better if we're patient.
When do you, at what point do you pull the trigger on doing something more than counseling, either injection, which I use in my practice, or getting advanced imaging.
I'm not a big fan of advanced imaging in this situation. I think there can be a role for it, but my first step, let's say we get to 9 months and the patient's just not happy with you, not happy with their wrist, and you got to do something. I think our corticosteroid injection is an incredible tool. I don't repeat it typically. It's sort of one and done. And I give it with the concept of I tell the patient, I think it'll make you better. If it does make you better, we learn something. And if it makes you better only temporarily, then that's when I personally think about an arthroscopy as the next step. But it's a great anti-inflammatory and it usually helps people.
You wait 9 months? You're so mean. Like usually, if it's, I'll go for. Honestly, if it's 3 months, I just go ahead and do it.
Oh, wow. I don't go that early. I tell them to suck it up.
Why wait though? Just out of curiosity. I mean, I think I'm out of the woods there in terms of potential concern for infection, et cetera. Way out of the woods. So if they're struggling, it may unlock, the ability to work through things a bit more with therapy. It honestly, it doesn't come up that often that I'm giving a steroid shot, but I've been happy with it. So I don't make them wait.
Yeah, 3 months feels early to me, not because I'm trying to hold out, and I agree with your points. I don't think it at that point you're not going to really worry about healing impact of the steroids and infection is not really a concern. So I don't think I wouldn't disagree with it. I just think so many people get better between that 3 month and 6 month interval that it's probably not necessary. But what it does do is makes it look better.
Yeah. It's funny. I used to, I think it's important to obviously understand the literature, where this is not a huge area, but, for tennis elbow for injections, I've become more lenient about giving injections. Although I used to stand on principle about the literature and, how it did make a difference, et cetera. And I'm like, there's sometimes it just does help. And I tell them that it might not help based on what the what the literature says, but I found it to be useful. There is some elements of patient satisfaction, and even though are obviously risks with any injection, this is one where I think the upside is much bigger.
Listen, and I may have said this on the pod, I may not have. My dad's a ENT down in Alabama, recently retired. He stressed to me that patients want something, and it's incredibly important. Now, I I quibbled a little bit more with his approach, which is they came in with a likely a viral whatever infection. He would give antibiotics, but they got something, and when they got better, who got the credit? And patients want treatment, and so we don't want to do something that could potentially be a negative for them. But I agree with you, the literature is really important and we try to be science based, but I don't fight so much anymore about injections for tennis elbow.
Yeah, yeah, I totally totally agree with that. Perhaps not the antibiotic part, but So in terms of Cal's question, how many times in your decades long career have you performed an arthroscopy after distal radius ORIF?
So this is the beginning of my third decade. Where are you? You're in the middle of your second decade. We're not that far apart,
I'm
dude.
at the end of my first decade in practice.
Are you really?
Towards the end, not even at the last year, towards the
Oh,
end.
you're only in your ninth year, is that right?
Yeah, I'm currently in the 9th year.
Oh, wow. Okay, we're a little further apart than I recalled. What was the
Well,
question?
you were recruited as a resident in the late 1900s, I believe. So.
It's true that century. What was your question?
How many times in your decades long career do you think that you've done a scope after distal radius ORIF? And what have you seen in that arthroscopy, and how have you intervened? Is it a debridement? Is it a repair? What are you thinking?
So it's a great question, and I would say this of the patients, and this is not about me, but of the patients I've treated for distal radius fracture, the percentage that end up going to the OR for arthroscopy is probably 1%, maybe 2%. I mean, something incredibly low. If you look at kind of all patients that I take for an arthroscopy and look and see what percentage of those patients had a fracture at some point in their past, maybe that's 7% or something. But both are low, but I don't think in regards to Cal's question, we end up doing scopes on many of those patients, and maybe because injections, when required, are helpful enough.
Now, you quickly mentioned something I think is super important. That concept of the radial shift or the coronal shift of the into fracture pattern. So that's one that when I was in training, Scott Wolf was really hot on, and I think it was I think the surgeon in Australia is Mark Ross, who has published pretty extensively about it too. I did a couple of projects related to it, and I learned a lot in doing them. There can be subtle shifts in the coronal plane that can make a difference for DREJ stability, at least in the lab, and I think I've seen that in patients too. But I've also endeavored to really get that coronal alignment of the metaphysis over the shaft during surgery. So what's been your experience with that? And then do you have any pearls on how to get that alignment correct?
Yeah, it's a really important point, and it is it's sort of a different reduction maneuver. Now, sometimes it just comes back in place, but other times I have struggled to align things coronally, and there's different tricks. Some people will put a laminar spreader between the shaft of the radius and the ulna, and you open the laminar spreader, and that helps the reduction. I think that's a perfectly reasonable tool when necessary, and by doing that, you bring the distal aspect of the radius back on top of the shaft. I don't know that the technique, other than something like that, if you have to, matters all that much, but I'm interested in your take. But I do think you want an anatomical to help the soft tissue healing process.
Yeah, I like the laminar spreader technique and use it occasionally. I have some concerns about being too aggressive with that because you are, introducing some potential for scarring in the interosseous membrane, that kind of thing. So it's that, and then also, honestly, getting a lobster claw type fracture clamp on the shaft and using that to manipulate. Some of the newer implants do have a kind of oblong hole in the coronal direction so that you can shift in that manner, which is super helpful. Honestly, it depends on the fracture, depends on the day in terms of who you have with you and whether you have to do that maneuver yourself or whether you can, have somebody else put the screw fixation in while you're holding, the attending maneuver. You're about to get thumb cramps because you're holding the reduction for so long. But I think that it's important to do. I think it's becoming increasingly recognized. So I think when you're looking at the fracture pattern, make sure you recognize that, and potentially even talk to the patient about the issues with ulnar side of wrist pain afterwards. The other one that becomes a little bit concerning to me is that the fragment of Bergen, as I call it, because our partner has published a couple of papers on it, looking at that dorsal ulnar corner piece. I think that's useful to understand the implications that might have on ulnar side of wrist pain down the line too.
I think that's well said. Both of those points. And, the DREJ configuration, if the fracture extends to the DREJ, can matter. I haven't been as impressed with Brogan's fragment, but I think it's a relevant consideration, especially when there's comminution.
So, Cal, hopefully that helped. And, I'd love your thoughts on it. I know, Cal, you see quite a number of patients and you've recently been in training. So if you want to share your thoughts, please email us back. Hopefully that answered your question. We should shout out our first sponsor. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Being a physician is hard. Becoming a physician is hard too. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/theupperhand.
How many times do you think you've read that copy and now you're flubbing it now?
I'm loving it. It's interesting. I'm just tired. It's been, I'm ready for a little time off, and I'm tired. No excuses. No
That,
excuses.
one of the things we'll talk about briefly later is energy, and it's such a hard thing to bottle and to really harness. And I think one of our first leadership talks when Rick Wright was in charge of the series was about managing your energy. And I think that's super important. It's one of the things that when I talk about this, it's just knowing when you're at your sharpest, but kind of on a weekly, daily basis, but then also on a sometimes you're going to have deviations from that, and recognizing that and saying, I can't do that today. It's just not the right thing to do right now.
Yeah, that's really well said. Before we jump into that, we've had some good discussion. Do you want to do a brief case?
Yeah, I'd love to hear your thoughts. So I've seen some patients recently, and I'm still trying to figure out the best way to manage thumb CMC arthritis surgically when it comes to it. And I think that your recent paper has been very helpful in terms of comparing outcomes after LRTI, the Burton Pellegrini type technique with the FCR suspension versus a suture tape suspension, which is all the rage nowadays, or at least it was. Much difference in terms of outcomes. We're still searching for, I think, the ideal technique. Do you have any? What's the role of a thumb CMC arthrodesis fusion in your practice? And you're muted.
Yeah, the CMC fusion got a bad rap maybe 20 years ago, and it did because of the rate of non-union. And it's a fair consideration, because the last thing in the world you want is to have to go back and do another surgery. I think CMC fusion is a great operation, and done in the right patient. I strongly believe they will be happy, and they will come back for potentially the other side if and when that is necessary. So I really like the CMC fusion. I think we have a few advantages today versus 20 years ago in obtaining healing, but I think it's a really good surgery.
So you mentioned how it got a bad rap. I mean, there was that study in the UK. It was I think it was the UK. At least it was published in the British Journal. But it was, you know, a randomized study that was actually halted early and stopped early because of the unacceptable, quote unquote, rate of non-union in the CMC arthrodesis group. And, you know, that I think really set that procedure to the side for a long time. But I think it was Dr. Gelberman and you were the big believers in this surgery. And I think during the last few years of his practice, you guys had a series that was published with was it KJ Hippensteel back in the day,
Nice.
orthopedic resident in our program, looking at CMC arthrodesis, and there were some non-unions, but the rate of symptomatic non-union was very, very low.
Yeah, I'm not even sure I was on that paper, but yeah. So I think that the two things I think about: one is the hardware utilized. Obtaining compression, I believe, matters, and two, I always use distal radius bone graft. But those are the technical things which I believe matter. The indications matter too. Do you have a patient population where you think about this operation, and also how many times a year do you think you do it?
I probably do 3 or 4 a year. It's probably 5 to 10% of my thumb CMC surgeries. I really like the surgery. My indications for it tend to be the laborer. Classic indications for it. Honestly, it's a person with bigger hands too, because doing an arthrodesis on somebody with the smaller trapezium is honestly just kind of hard once you've cut back on the arthritic bone surface. So it's technically more challenging. So, but the person with the bigger hands who is either a laborer and has years to go on that, or if they have activities that are kind of relatively, heavier. So in terms of like aggressive yard work kind of thing, that to me is a great patient for it. And, the patients who do well are very, very happy. And, that's been my experience so far. What are your indications? And then also, technically, how do you prepare the joint surface? Are there any pearls that you have in your decades of experience?
Yeah, so my volume's not much different than yours. It's 5 or 6 a year, maybe less. It is the younger laborer type population, so I would say less than 50 for sure, and maybe closer to 40 is my typical patient. I've done 2 recently. It's so my preparation of the joint, the base of the metacarpal is easy. Simply because the bone is not so sclerotic, and obtaining great cancellous bone. And that is a key that I don't think I realized earlier in my career. You want great cancellous bone, not just good bone. So great cancellous bone. I like the cup and cone technique, where the cup is the distal aspect of the trapezium. The cone is the base of the metacarpal. So you prepare the metacarpal, make it as cone-like as you can, so as rounded as you can. And then working on the distal aspect of the trapezium is a little trickier, because it's just dense sclerotic, and you have to get past that sclerotic bone. So for me, it's usually a sharp rongeur and with a streak down the center, and work on either side, like Dr. Gelberman taught us, and perhaps a burr, although I'm not a lover of the burr. What about you?
Yeah, similar technique. I had a fellow, I won't say when, who was all about using the saw for these, and I don't love it, to be honest with you. So, I do the Ronger technique. I think one of the tricks on the trapezium is really recognizing how you have to get out to those radial and ulnar horns on the trapezium and getting those down, because those can be a little bit tricky because of the sclerotic nature of the bone out there, and the osteophytes that are there. So, and recognizing that, if in terms of who has the angle, to use a Goldfarb quote, in terms of who's doing which parts of the surgery, I prefer to be the one doing the trapezium, unless I'm very comfortable with the person on the other side of the table, because you have less chances with the trapezium that it can quickly evaporate with an overly aggressive preparation, so to say. More chances on the metacarpal.
Yep, exactly right. And then again, I add cancellous bone graft, even if I have a perfect fit. If the cup and cone is perfect, I still add cancellous bone graft. And my goal, usually it sits where it's supposed to sit. And of course, we didn't mention the one warning to patients. The one thing you have to tell them is you can't put your hand flat on the table after the surgery. If they know that before the surgery, they will be fine with it. But resting posture is thumb should lie over the middle phalanx of the index finger. People talk about 30 degrees of abduction and et cetera, but I just think it's simplistically have it rest over that middle phalanx.
Yeah, line it up for pinch, right? So it's a different. I've found the thumb CMC arthrodesis to be different in the arthritis population versus the plexus population. Because for the plexus population, I'm really trying to get their thumb completely palmarly abducted and more in a position for opposition and pinch. They just want it out oftentimes. I don't know what your experience has been for using it for other indications aside from arthritis.
Um, None. I really don't think so. I'm glad you're doing those patients instead of me.
And then technically, you mentioned that we have advantages now. I mean, I'm sure we had the technology back then, but we didn't use it. So what's your fixation of choice? Are you a big K-wire guy?
Yeah, not a K-wire guy, even though there's nothing wrong with K-wires in this situation. And I think if things go awry for whatever reason, be comfortable and confident using K-wires. I think there are some specifically designed plates for this that give you a couple of advantages. The one advantage I think is most important is it gives you the potential for compression in a low profile plate that's not likely to bother the patient. And the second is a plate that also allows you to place a compression screw either in or outside of the plate and adds another point of fixation to fight toggle, I think is really important. And so there are a couple of options out there. The one I use with absolutely no conflict of interest is the MedArtist plate. It is expensive, but I think it's well designed.
Yeah, so I do like. I think it is important to get some compression. My experience is I don't use that plate just because I don't use any of the other things in their lineup. And again, no conflict with MedArtist. The the plate that I've used is kind of a standard 2024 kind of plate, depending on the size of the patient. And I used a 2-column plate. And then I'll usually cut off one of the rows, and then cut it in a way where I can actually bend the proximal part to kind of hug the bottom of the trapezium, and then put some compression through the plate on the metacarpal side, just with kind of a standard AO technique. So I found that to be helpful. And then I think it is important to keep it low profile if you can when you're doing your approach. Elevate the sleeve periosteum, off of the metacarpal to try and use that to cover the plate down the line if you think about it ahead of time.
Well said. Well said. This is a fun surgery, and patients get great outcomes. They heal in a timely fashion. So all good. It's a good. I would say it's a mandatory tool for you to have for certain patients because the LRTI or the trapeziectomy or the internal brace, those are not always right for every single patient.
Right. It's good to have things in your toolbox for sure. So speaking of things in your toolbox, let's shout out our next sponsor. Are you heading to the Bahamas for the AAHS, ASPN, and ASRM annual meetings later this month? If so, stop by booth B14 to visit our sponsor, Checkpoint Surgical. They're also hosting the ASPN Lunch Symposium on Saturday, January 13th, where a guy named Chris D will be presenting alongside Dr. Steve Lee and Dan Zlotalo about nerve injury reconstruction challenges. So you get lunch, you get nerve, all good. You can find the registration at the link in the podcast description or on nervemaster.com. I hope to see you there.
There is a link for registration if you were able to. I think you read the whole copy.
Oh, yeah. I did.
Perfect. All right, let's just keep going. I'll edit that out. All right, fantastic. So it's going to be a great meeting. I know you're going down. I think Brogan's going down. Dr. Wall is going down. So a good chunk of our faculty are going down.
Yeah, so is Dr. Morris. So I hope you're back to take a call.
I will be holding down the fort.
No, I think it's a fun meeting. I love the ASPN meeting as well as the association meeting. But there for the ASPN, I've had a really good time being on their executive committee. Learned a lot about the organization, and I love sitting in on those scientific sessions. I learned so much being there. So excited about being down. And Bahamas doesn't hurt either.
Is this a D family vacation, or is this just Christy
Oh yeah.
himself?
So no, the family's coming, and I am going to. I told my wife, I was like, look, I'd love it if you guys come. Like, I'm actually really busy at this meeting. Like, I'm gonna be at the meeting, like really at the meeting. The combined association meeting gets a rapid with your family. Like, I'm in for 2 days, full day.
Yeah. Those meetings are tougher unless your significant other can handle it and enjoy it and be with the kids perhaps happily on the beach.
Well, I think that's the key of having the Brogan and Wall families there as well, is that it becomes a group affair. So, yeah, it'll be fun. It'll be a good time. I'll catch them at dinner, maybe.
All right. We had talked about maybe discussing a couple of HBR articles, but I think let's focus on one if that's okay with you. And the article that we'd like to briefly discuss was actually shared with you and I by Marty Boyer, and it's entitled "The Best Leaders Have a Contagious Positive Energy." This article was written by Emma Seppala and Kim Cameron, and I'm not sure what year it was published.
April
2022.
2022.
Yeah.
In HBR. So if you want to pull it up on the HBR thing, the reprint is H06ZUL. For those of you HBR nerds.
Yeah, so this is these articles I think are helpful because what they do is they sort of either validate or educate us around things we think we believe are true and provide a little more evidence for success, honestly.
Yeah, well, so what they're talking about here is kind of the energy that somebody brings. And anecdotally, I mean, you are totally in charge of the energy in the room when you walk in. You could change it, you can shift it. And some of us are more conscious of that and try to affect the dynamics of a room. Others are more passive.
Yeah, that's right. And this article, like many others in this kind of type of HBR presentation, are based on a lot of work, a lot of interviews, and in this case, 2 decades of research on positive leadership. And it's really incredible that they focus on extraordinary performance, and they have found that one person is usually at the center of networks that are most responsible for forward motion and well-being. And the authors call those people positive energizers.
Yeah, I think it's the way that they did their research is that they took a group and then they asked people in the group, when this person, when I interact with this person, what happens to my energy level? So it could be a group of, for example, in this case, vice chairs or division chiefs, and you're saying, when Chuck Goldfarb walks into the room, what happens to my energy? So I thought that was super interesting that they were able to, to look at the people with more positive energy versus those with lower energy or negative energy, and see how that affected performance. I mean, how do you interpret this in terms of how you think about your leadership in our department? Group of surgeons, group of physiatrists, neuro rehab folks, and does that resonate? Does it make sense? And then how do you think about your own energy?
Yeah, it's I've thought about this in a couple of different ways, and I'd love your take. There are leaders that walk into a room that immediately get attention and immediately maybe get deference but those people are not always these positive leadership people. And I think increasingly in 2023 and tomorrow in 2024, we will see that it is positivity and collaborative leadership more than the kind of old school leadership, which is, takes the day. But this type of leadership, um, I've seen it. I know it works, and hopefully, it's not a type of leadership that requires conscious effort, because the best leaders probably don't have to do that. But those of us who are aware of this, even when we aren't at our best or at our most energetic, I think we can find something if we recognize these principles.
Yeah, absolutely. I mean, I guess they mentioned early in the article about how this is different than something like charisma, and you seem like a very high riz guy, as they're saying nowadays. How do you think about this as different from charisma? And is positive energy always kind of what we think about, the cheerleader, rah rah kind of thing?
I think, and they make the point of discussing those who deplete energy, and we know that type of person, right? It's kind of the wah wah person, and I don't think those people, no matter how smart they are, can be effective leaders. And so I do believe that people who are positive energy leaders often have charisma. But I think if you are supportive of those around you, if you give back what other people put out, and amplify that, you don't have to be charismatic. Do you think you do?
I think there's an association, like you're saying. Those people that have are more charismatic tend to have higher positive energy, just in general. I think, but there are ways. I think it's as as people have been saying recently, it's context dependent. But I think it's situationally, where you are, that matters. Like your positive energy you can bring uh, to the OR is different than the one that you bring to the clinic, and it's different than the one that you bring to the boardroom meeting.
Yeah, that's exactly right. And this article makes the point with a personal example that you have to be at your best to be able to reflect the positive energy around you. So, you need to take care of yourself to be in the right frame of mind, to be that positive leader. And to me, positive leadership is a lot of different things, most of which are addressed in this article. It's making people around you feel good. It's not stealing ideas, it's amplifying the ideas of others. I mean, there's just so many examples. But when you do that, or when the group does that, honestly, is the best situation where there's a lot of positivity. People are happier, and we talk so much today about well-being and feeling a sense of belonging. All of those things go together.
Yeah, totally agree. And I think that that's probably some of the emphasis on getting back to meeting in person again, is that you are more likely to get that positive energy, in person than on a Zoom screen or whatever, So I think there are some people that do that better than others, and you have to work so much more intentionally if you're meeting remotely, than if you're in person, just because it feels more organic and you're just honestly happy to see people when you're together.
I think that's really well said. And I don't, you can work really hard on a Zoom, but as you say, I don't think you can do it. I think in person is required for some of this. And so trying to find the time for in-person conversations that build a team, build a department, build a practice, however you want to think about it, a practice that, will be innovative, a practice that will kind of move the field forward and create happy patients if it's a medical practice. All of those things matter so much, and Zoom is convenient. Zoom doesn't do it.
Yeah, and I think Zoom can work for some situations in terms of like sometimes a one-on-one meeting with somebody that you know very well, that can work. But if you're trying to lead a big group, it is incredibly challenging. As we wind it down, I'd love to hear your thoughts on how you bring examples of how you bring positive energy in three different situations. One, a leadership meeting. Two, the OR. And three, the clinic. I can start since I kind of sprung that on you. But I think for me, positive energy for the OR is really getting the team on the same page from the very beginning. If there's somebody new in the OR, making sure to introduce everybody. I did that recently, and that was a big hit. And somebody actually told me, they're like, that was really nice. I felt very included. So I think that's one example for me in the OR. How about you?
Yeah, that's really good. And I was a little taken aback that you were putting me on the spot for three examples, but I think they're the right ones. So I think about, when I'm in the OR, and let's face it, I think probably most of us are like this, especially first thing in the morning. We may not be at our best energy wise. And if you have the same team with you week in and week out, that's okay. But when it's not okay is if you have new people, a new team, which increasingly is happening in our ORs, and I assume ORs across the world. I think then you have to bring your A game and your energy when you start. Because if you are that rah-rah person at 7:30 in the morning when your OR is starting, it really risks having your OR go in the wrong direction all day. And so it is what you said. It's involving everyone in the room. It is bringing energy about, hey, we had a busy day. We're going to get this done. We're going to take great care of patients. It is being a little rah. It's just bringing energy.
Yeah, you are, I think as a surgeon, you are disproportionately in charge of the energy in the OR. I mean, anybody who walks in the room can change the energy, but as a surgeon, because of the de facto leadership position, if you're having a rough day, everybody will, that will shift the outlook on the day. So and I've told this to trainees before. I mean, to be very honest with you, the only person that usually knows that a case is trickier or more challenging than expected, or you're getting into a problem, is the attending typically. And sometimes it's a really that understands what's going on. So if you keep your cool, and you keep good energy, the rest of the room, won't even notice if you all of a sudden are dealing with a technical issue. Now, if sometimes there's a moment for this, and you have to kind of get everybody's attention. But if you start freaking out, everybody's going to start freaking out. So you got to really keep your cool.
I think that's a really, really important, especially for those in residency or even in medical school. It's critically important. And you can, let's say, and this has happened to me, I'm doing a procedure, you're taking out a volar wrist ganglion, simple surgery, not a lot of stress involved, and you notice there's a nick in the radial artery. If you freak out and talk about blood spurting, and then everyone's aware it's a negative, it's going to affect the energy for that case and cases moving forward. But if you calmly ask for a nylon and maybe a micro set, no one bats an eye. It's unbelievable. As you said, no one bats an eye. So if you keep your cool and just address the issue, it'll be fine.
So for clinic stuff, I mean, how do you you have busy clinics? I mean, how do you keep the energy going in the clinic, from the jump and then throughout the day?
I think the hardest part of clinic is not the typical patient, because we're lucky, right? We are in orthopedic surgery. Patients are typically happy. And if we can address their issue, they will come in happy and they'll leave happy. The problem or the difficulty is the problem patient, the patient that's not happy for whatever reason, who comes in, and those individuals are energy depleters. And we all know that one patient like that can honestly ruin the whole day. Whether it takes the time, takes our energy, and then we have less energy to put out in the world. And so I think it's really important in those situations that we have to, we, the surgeon, the main person, need to address and work with that patient, not let the whole team be drawn in negatively with that patient, and try to just deal with it the best we can, and then find more energy to move forward. What do you think?
Yeah, no, I mean, I think that there have been days where clinic has gone surprisingly well in terms of efficiency of time and happiness. And then it's, I look at my MA and I'm like, well, that clinic was awesome. Like, what happened? And she's like, you didn't have any nerve patients. It's like, oh, okay. Or like the challenging nerve patients. I've tried to structure templates so that complexity of patients and the people that are likely to be longer and more involved visits. Not necessarily energy depleters, but just things that can slow clinic down. I tend to put them during times where we have a little more leeway. And then knowing that patients sometimes can be more challenging in terms of their situation, their happiness, their demeanor, et cetera. Some of those patients, I intentionally say that patient needs to be the very last appointment when they come back next time.
Yeah, it's really smart. It's also not easy to do, but it's really smart to handle it that way. And I like you, like everyone listening, understands that there is no way to look at your schedule on the morning of. You can have the same 60 patients 3 weeks in a row, and that clinic flow, that energy level, that enjoyment varies from week to week. And there's simply no way, and that I understand, to predict it. And you just have to hope the next day is going to be a good one.
Yeah, absolutely. And honestly, there are things that we do during clinic to kind of keep keep some levity. We have a little whiteboard that occasionally people have been known to draw or leave comments on. Usually, the whiteboard is for actually like gridded with the rooms, and I think that was a Dr. Gelberman thing that I've incorporated, in terms of having a board where to write like what to do. Because sometimes there's a lot of asynchronous communication in clinic. Like if the MA is in the room already and I'm walking out, I want to do an injection, et cetera, I'll write it on the board. But there have been various tallies of things or drawings or, that just kind of keep the mood light. And I found that very fun.
Yeah, I think that was a Rick Wright thing. Maybe Gelman even got it from Rick Wright, but I think that's good. And your last scenario was a meeting, a leadership meeting. And I think there's a couple of principles. Number one, don't have a meeting unless you need to have the meeting. We're all meetinged out. And so there's really good reasons and really important reasons to have meetings. But if there's not a compelling reason to have a meeting, send the email instead. So that's number one. Number two, as you said, in regard to the OR, lay out what you need to accomplish in that meeting and do that at the beginning and then summarize it at the end. And then thirdly, it's the same thing. Bring positive outlook and energy and a positive approach to dealing with the issue or the opportunity or the strategy, whatever you're there for. But that energy is palpable and can get you off in the right direction.
Well said. I don't have much more to add. I'm trying to get better at listening and not thinking about what I'm going to say next. And I think that indirectly relates to what you're saying about giving support to somebody. Because if you don't listen to them, you're not actually going to be able to support them. And if you don't agree with them, taking a minute to process it and think about it and consider their perspective before either refuting them or trying to ask clarifying questions.
Yeah, and that's a whole episode in and of itself. Of course, I agree with you. It can be hard to listen and process and figure out what you're going to say next. But I love what you said. I mean, when someone says something that you don't agree with, there's a couple different ways to respond. One of those is to state your disagreement, which can be okay if you have a strong reason why and how you think about it differently. More and more, I'm doing what you suggested, which is try to understand why the person feels the way they do, and that'll help inform you to make a better decision and response.
So last episode of 2023, we're jumping into the new year. I hope we'd love to thank everybody for listening to us. If you made it this far, you're a very loyal listener. But feel free to send us emails, communicate with us about things you want to hear about on the podcast as we jump into 2024.
Yeah, I mean, there's so many topics. Thankfully, we aren't there's no shortage of topics, but we want to talk about what matters to you. So the more you communicate with us, the better we can be at that task. From the Hand Society coding app to HBR articles to technical, we love doing this and look forward to 2025, which will be our
2025?
2024. Good point.
It's aggressive.
So yeah, it was still our 20, 21, 22, 23. This will be our 5th year, right?
Yeah. All right. We're still going strong. Apparently skipping ahead years even. So,
Yeah.
all right. You
I'd
have a
edit.
good day.
All right. Take care.